The Nigeria Center for Disease Control has confirmed 123 cases of diphtheria disease and 38 deaths in 4 states. Dr. Priscilla Ibekwe, head of Special Projects and Partnerships Unit at the NCDC, says the agency is working with state ministries of health and partners to enhance surveillance and response to the outbreak. Giving a state-by-state breakdown, Dr. Ibekwe says Kano has the highest number of diphtheria cases with 100 infections and 32 deaths, followed by Yobe with 17 cases and 3 deaths, then Lagos with 5 cases and 3 deaths, and Osun with 1 case and 0 deaths. The NCDC says it is supporting states by providing antitoxins for the treatment of confirmed cases while urging Nigerians to ensure that they are fully vaccinated against the disease with the prescribed pentavalent vaccine. Diphtheria is a bacterial infection that affects the nose and throat, causing difficulty in breathing. It spreads easily through direct contact with infected people's droplets from coughing or sneezing and contact with contaminated clothing and objects. Joining us now via Zoom from Tennessee is in the U.S. is a public health physician, Dr. Usman Bashir. Good morning. Thank you for joining us on TVC Breakfast. Right. It seems we can hear you.
Okay, can you hear me now?
Yes,
sorry,
I can hear you now. Right.
Sorry.
By way of helping us better understand diphtheria, what are the main causes of diphtheria? And if you could just shed more light on what diphtheria really is.
Good morning. Thank you for having me. And as we know, diphtheria is one of the childhood killer diseases we know, especially for under 5. And it has been ravaging in the last centuries. But, with the coming of vaccines, it has revolutionized and taken the disease back into the back seats. In the past, we use the trivalent vaccines, that is DPT, whereby diphtheria, pertussis, and tetanus were given to children, usually in 3 doses and at an interval of 4 weeks, beginning from 6 weeks, 10 weeks, and 14 weeks. So that has gone, and now we are even additional molecules were added. That is now is pentavalent, meaning that additional Haemophilus influenza and hepatitis B antigen were added to the vaccine. So, but the challenge we are having is what we call 0 dose. When you see this kind of disease, vaccine treatable disease coming up, it shows the weakness of the system. It shows that there are large numbers of what we call 0 dose children, which are children under 5 that have not received any dose of vaccines. And unfortunately, about 60% of 50% of these 0 dose children live in 3 key geographic contents, meaning urban areas, remote communities, and population in conflicts. And then when we look at these numbers, 70% of 0 dose are located in 5 countries: Nigeria, India, Democratic Republic of Congo, Pakistan, and Ethiopia. And 20% are in fragile countries where there are crises. And then there are substantial numbers or variation between these 5 countries I've mentioned. Like, for example, in DRC and Ethiopia, they have the largest number of 0 dose children in remote rural areas. As you know, their terrain and the kind of geography there. While in Nigeria, which has the largest number of 0 dose children, mostly those in the crisis zones, either IDPs or other form of infection. So it's very important for us to, this is a warning sign for us that our, like I said, our immunization system is not reaching those people. And then, like you said, the numbers you've mentioned, Kano having 100 confirmed cases with about 32 deaths, which brings case fatality of 32. And in Lagos, they have five cases in 3 days, which has a case fatality of 60. And then Yobe with 17 cases in 3 days, which is also about 17% case fatality, with an Ocean with 1 case and 0 death. Even though usually the usual case fatality is 10%, you can see the other 3 states, the numbers are high, which means this can spread to other states. And Kano and Lagos are highly urban states, which if care is, and then we have a lot of urban slums, a lot of children who are not vaccinated, and a lot of mobility, people moving from Kano to Lagos, and that can spread across. So there's need for us to quickly identify, especially our healthcare workers need to be alert to quickly identify children with symptoms. They usually come with respiratory symptoms, which later turns usually the symptoms appear between 2 to 5 days, and complications usually occur, or the severe form of the disease manifests after 2 to 3 weeks. And by that time, usually little or not much can be done. So it's very important healthcare workers have high index suspicion for any child or anybody that comes with respiratory symptoms, and they need to examine them out so that they will see those whitish plaques or membrane formation by the exotoxin, and they need to start the DPT antitoxin, and then also antibiotic treatment. And then there's need for surveillance and contact tracing so that all contacts of that suspected case or confirmed case should isolate themselves, should be given some antibiotic for at least 1 week, and then we can nip in the bud. But the most important thing, we said, parents should take their children for immunization. Let them have their complete doses at least. And then, like I said, the numbers in Kano mentioned, I have the data, and as of yesterday, 100 cases, like we said, they're affecting 13 LGAs, mostly metropolitan areas, and then 8 cases were positive for the culture, and 3 were positive 6 were produced by the oxytocin, and we have 32 total deaths, and there are 3 deaths in the confirmed cases, and then we still have 27 active cases on admission.
All right, Dr. Bashir, one would want to ask why now? Why the rise of or at the outbreak of diphtheria at this time? Is there any explanation why that is happening now? Because in the past few decades, even if we had them, or years ago, we didn't record them in this proportion.
I think, like you said, it means our 0 doses are coming up, and the weather, now we're in dry, cold weather season, and which helps facilitation of our droplets, and also maybe our surveillance system is improved. We're now having an improved surveillance system. We have PCR machines around the country which can aid their diagnosis, which is helping us to wake up and then see to this. And also, like I said, it's workable for us to tell us that we are not doing well. Our 0 doses are coming up. So, like I said, it's an indicator, and also it's something that shows how our surveillance system, NCDC, is up to its game. As you can see, there are releases coming up. It means the surveillance system at the LGA level, it's at the LGA level that you find this case. It means the PHCs are becoming, our healthcare workers are becoming more skilled, and then because the telltale signs started in November, and then in Kano, the numbers beefed up in December and up till now.
Right. There are those who say that, like you rightly mentioned, the matter of compromise in vaccination or zero vaccination, like you mentioned earlier. Now, that brings us to the matter of vaccine hesitancy and at some point, vaccine resistance, rejection. How do we deal with such matters in areas like Kano and Lagos, where we are seeing the numbers and the possibility of it even spreading across the state? How do we deal with this matter of vaccine hesitancy and rejection if we are to tackle this?
Yes, it has been going on, like you said, and we need to our risk communication strategy, meaning that we need to engage the stakeholders, and then everybody is now, like the media is doing now, people now are seeing that this disease are childhood killer disease, which we have known in the past, and then they have been ravaging our children, and there's need for us now to it's not only the hesitancy and rejection, even the access to the vaccine. Some communities need those, they don't have anything, but they don't have, they're not rejecting or they're not hesitant. But it's either that there is breakdown in the cold chain or the logistics and supply to those communities, or even the skill manpower that provide it, and then or the terrain is not favorable for people to reach the facility. So it's not only hesitancy, it's not only rejection, it's also about access. We need to provide access to those hard to reach communities, those rural areas, so that those children in the rural areas can be protected and everybody will get protected. But like I said, we need to improve our risk communication strategy. We need to talk to our people in the ways they understand. Sometimes it is the way we pass the message or the way we package the information that people, it brings about suspicion, it brings about rejection. And then sometimes we're not reaching out to our gatekeepers, maybe traditional institution, religious bodies, the people that people listen to. There are some people that stakeholders, we call them. People listen to them, they take their advice, they trust them. So we need to reach out to those people and then pass the right information like we're doing now, so that people understand the risks and the danger we're in, and for the need for parents to protect their children, and the need for adults also to get protected, and even the elderly. So as you know, this disease also affects people above 60 years old. So it's not only the children that are ravaged, even the elderly, because of their low immunity or they have not had the vaccines done.
All right, Dr. Bashir, from the reports we're getting, besides those who have been confirmed, there are still suspicion that there are so many other people who would not have been out or reported to the hospitals to be documented. How best can those who are already infected or affected, how do you manage diphtheria?
Yes, like I mentioned earlier, if somebody is immunized, he might be a carrier, and then he'll be spreading the disease because the disease might not show. It's what we call virulence, ability to multiply and then release the toxins that destroys the membrane. Even though I don't want to go into I don't want to go into medical jargons, as we call it. But so we need to really understand these people, and then also the need for anybody that has cough or any other symptoms, cold, cough, cover, to report to the nearest center. Not only reporting to the center, listening to instruction, isolate himself for at least 10 days. But science has shown, if any suspected case or anybody starts taking antibiotic after 2 to 3 days, is no longer being infectious. And then most of these cases are being managed in isolation centers. Like in Kano, they are managed in the COVID isolation center. So they are being managed in isolation center. Their contacts are being traced, and they're being also investigated, and those with symptoms are being monitored for at least 10 days. So it's being done, and it's ongoing.
There are reports that diphtheria comes in different forms and types. Could you shed more light on that?
Yes, there are different species, like the one we know, Corynebacterium diphtheriae, Corynebacterium tuberculosis, and then even it comes with the skin manifestation. But even though the skin manifestation is not life-threatening, it's not usually severe, and is self-limiting. But usually the one that affects, the one that is life-threatening is the one that affects the airways, and then when it's complicated, it affects the heart, causing what we call endocarditis. It can affect the kidneys and other organs, which can lead to, and then it can also spread in the blood, causing what we call septicemia. That's overwhelming infection, and even which can lead to death.
All right. Can you share with us the mode of transmission so that people are more conscious of some of these challenges and things they should look out for?
Yes, the mode of transmission, like I said, is droplet infection, meaning that if somebody coughs or sneezes or close contact with maybe sleeping in the same room, that's why we said in urban slum, where people sleep crammed, especially now during cold weather, where people close the windows and then stay in the same room and sleep in the same room. So if somebody has the infection, he can transmit the infection, and even sharing of clothes. So there's need for us, if we are coughing, we should have what we call respiratory etiquette. Even if you don't have, if you're going to cough, you should use your hand to cover, and then use face mask, and then also isolate yourself. So, like I said, those are the modes of transmission. It's usually by droplet infection, that it's spread on air, just like any other respiratory infection we know.
So how can parents help beef up the immunity of their children and even adults at a time like this? Because immunity is key at dealing with this virus.
Yes, like you said, disease is severe especially in under fives, even though sometimes it can occur in adults who are not immunized. So the most important, like we said, is providing complete vaccine for under fives, meaning they should get the 3 doses of the pentavalent and other vaccines. But at this point in time, and then even there are doses for adolescent children, meaning children above 7 to 14 years, they are being given booster doses for those that have been given in immunization. And then even elderly and adults, there is a dose for them. And then I've seen that in the NCDC results, it released that it's available for those that want to get vaccinated, so that people can, and the more we vaccinate, the more there will be herd immunity, and the less likelihood we will hear more that diphtheria is coming back to us. So the most important protective is prevention, and which is cheap, affordable, available, and it's free. It's not being sold. So it's something we can easily access. And then, like I said, for those communities that cannot access it, there's need for government to ramp up, especially the National Primary Health Care Development Agency, for it to provide, to improve the logistics and other things in providing these pentavalent vaccines for our teaming under fives.
All right, we'll have to leave the conversation here now, but we must thank you, public health physician, Dr. Umar Bashir, for your time on the program.
Usman, sorry.